This is our TCD and vasospasm talk, and you are watching TCD with Tony. Here is a breakdown of the types of strokes. We have two main types of strokes, ischemic and hemorrhagic. The majority of strokes are ischemic, 85%, and then the other 15% are hemorrhagic. They are broken down between intracerebral and subarachnoid hemorrhages. And this is what the different types of strokes appear as. You can see that the ischemic stroke has a clot within an artery blocking off the blood flow, and the intracerebral hemorrhage has bleeding into the brain. You can see that in the center picture. And then the far right picture with the blood around the brain. This is blood within the subarachnoid space, and this is a subarachnoid hemorrhage. This is going to be the main talk we will review today on these next slides. Now, a subarachnoid hemorrhage is a life-threatening emergency. As we said, it occurs as a bleed happens in the subarachnoid space between the arachnoid membrane and the pia mater. Now, this is an annual incidence in the United States between 10 and 14 cases per 100,000 annually. There are risk factors for subarachnoid hemorrhage and strokes in general. Some risk factors we're going to review are hypertension, smoking, heavy alcohol use, drug use. Age and sex can play a role. At younger ages, men are more likely than women to have a stroke. Women tend to live longer, so their lifetime risk is higher. And then with birth control or hormone replacement, this can raise a risk for stroke. Also, women are higher risk during pregnancy in the weeks postpartum. High blood pressure during pregnancy, such as preeclampsia, raises risk of stroke later in life. Another factor is race and ethnicity. In the United States, Black, Alaska Native, American Indian, and Hispanics are more likely for stroke than white adults. If you have a history of a subarachnoid hemorrhage, a recurrent episode is more likely to happen. Subarachnoid hemorrhage clinical presentation. The patients most often say, "I have the worst headache of my life" at presentation. Along with the worst headache of life is nausea, vomiting, loss of consciousness can play a role, photophobia, and neck pain. And most likely this is secondary to a ruptured cerebral aneurysm, which you'll see here on the right. In this picture, you can see that ballooning out where the white arrow is pointing at. That is the aneurysm that is ruptured, causing this bleed into the brain. The recently published guidelines for the management of patients with aneurysmal subarachnoid hemorrhage from the American Heart Association and the American Stroke Association recommend TCDs with aneurysmal subarachnoid hemorrhage. It is proven that TCDs are beneficial in detecting vasospasm and can help predict delayed cerebral ischemia. Aneurysmal subarachnoid hemorrhage is not the only type of subarachnoid hemorrhage that benefits from routine TCDs for vasospasm. Traumatic subarachnoid hemorrhage, or TBIs, a traumatic brain injury with subarachnoid hemorrhage, is now increasingly recognized as a clinical entity with potential significant consequences. After head injury, subarachnoid hemorrhage with blood around the basal cerebral arteries can lead to vasospasm, causing delayed cerebral vessel narrowing and ischemia. Martin et al. Suggested that patients with significant post-traumatic subarachnoid hemorrhage be examined frequently by TCD for the presence of vasospasm and hypo or hyperperfusion states after brain injury. Let's just take one step back and do a brief anatomy review of the cerebral arteries. Here on your right is the temporal window that the transducer is placed, and we are insunating the right MCA initially here. The first segment of the MCA that we will see at a depth of 30 to 40 millimeters on an adult will be your M2. This will lead on to the M1 segment and then the bifurcation of the MCA and ACA. So the MCA and ACA bifurcate from the ICA here, which is typically at a depth of 62 millimeters in an adult. So your MCA branches off and comes towards the probe, and the ACA branches off and goes away from the probe. This continues to bring the blood flow to the front of the head. The A1 will continue on into the A2, which we typically won't see with TCD, and then the A1 on the other side of the head will be the next vessel that will be visualized as we continue deeper, and then the left MCA on the other side of the head. And here we're continuing on with anatomy with our aneurysms. So this slide, as you can see, the MCA here on the right. This is your ICA, the MCA coming off, just as we said on the last slide. This is your ACA coming forward, your ACOM, which is connecting your two ACAs. Here's your other ACA, and here's your other MCA. So in the middle here, here's your ICA, and here's your ICA. This is the front of the head. This is all going towards the front of the head. This is the back of the head. This is the basilar artery, and these are the two PCAs that are coming off of the basilar artery. So here we're showing where the most common aneurysms occur. Now the aneurysms can occur at any segment of these arteries. This is your circle of Willis. The most common aneurysms you see here are in your ACOM, this little vessel that connects your two ACAs. Here's your A1, here's your other side A1. It continues forward to your A2. These segments up here are your A2. This ACOM is a small connecting vessel. This has 40% of your cerebral aneurysms. Now your MCA and ICA will have about 34% of aneurysms, and then the basilar tip has a 4% range of aneurysms. Just to get an idea of where the most common location is for these aneurysms to occur, obviously you can get them anywhere throughout the circle of Willis, but this will give you a general perspective of what you will see in most scenarios. Subarachnoid hemorrhage has 3 different scales we're going to review that help determine the severity of each situation. Now this one that we are going to review first is the Fisher scale. The location and extent of subarachnoid hemorrhage bleeding is determined by non-contrast CT. Vasospasm frequently occurs in the basal cerebral arteries, as we have reviewed in the prior slides. Occasionally, vasospasm can be found more distally depending on the location of the ruptured aneurysm and the blood deposited around the arteries. I have found vasospasm only in the M2 segment on some patients. This is rare, but it shouldn't be overlooked. At the depths of 30 to 40 millimeters, the M2 segment was isolated, showing vasospasm only in this section. Just something to be aware of when you're scanning your vasospasm patients. The location and thickness of blood deposited in the subarachnoid space have a predictive value determining the risk of vasospasm and delayed ischemic deficits. The next 2 scales we will review are the Hunt-Hess scale and the Glasgow-Coma scale. The Hunt-Hess scale was developed in 1968 as a clinical grading system to predict prognosis and outcome in patients with subarachnoid hemorrhage. A higher grade predicts a poor outcome and lower likelihood of survival. The Hunt-Hess scale is widely used for categorizing severity of subarachnoid hemorrhage. However, it has been criticized for its inter-observer variability and minimal clinical difference between grade 1 and 2. Moving on to the Glasgow-Coma scale, this shows how the calculator will work, and it is to assess a person's level of consciousness or neurological condition. It assigns a score based on eye, verbal, or motor responses, with a higher score indicating a better outcome. Moving on to complications of subarachnoid hemorrhage. Vasospasm is a common complication of subarachnoid hemorrhage, which is often responsible for delayed ischemic neurological deficits. Here we have an image of the aneurysm ruptured, and you can see how the blood and the blood clotting around the arterial walls can aggravate the tissue and cause an inflammation process within the vessel. The most common cause of spontaneous subarachnoid hemorrhage is a ruptured cerebral aneurysm. However, subarachnoid hemorrhage can occur from other causes such as an AVM, an arterial venous malformation, trauma, and secondary to other etiologies such as anticoagulation or other types of brain injury. Also, with head injury following neurosurgical operations and all of these hemorrhages, they can lead to vasospasm. Aneurysmal subarachnoid hemorrhage constitutes the most severe form of subarachnoid hemorrhage. Other complications along with vasospasm include rebleeding, hydrocephalus, delayed cerebral ischemia, seizures, chemical and bacterial meningitis, in addition to other medical complications. These scales that we have reviewed can help grade the severity of subarachnoid hemorrhage. And this image can show exactly the process of what is happening within the cerebral arteries. Here is a good image to show what vasospasm really looks like within the artery. Now, most of the time you would think that you're going to have a spasm within the artery and the artery is constricting and the walls are, all of the walls of the vessel are constricting. However, this is not exactly the case. It is a twofold process. There is an inflammatory process within the vessel and a constricting factor that takes place. So you can see in this image here, this is the center of the vessel, and this is the outside of the vessel wall. There is an extreme inflammation process that is happening within this vessel. It's the breakdown of blood with hemoglobin and other products around the outside of the cerebral vessels enter the vessel walls, inducing biochemical changes. This leads to muscular contraction and vessel wall structural changes. This is characterized by collagen deposition that in turn result in narrowing within the vessel itself. Here is the vasospasm timeline. So vasospasm will occur and cause some degree of vessel narrowing in 70% of patients following subarachnoid hemorrhage. While cerebral vasospasm is typically seen with aneurysmal subarachnoid hemorrhage, it still can be seen in traumatic subarachnoid hemorrhage at rates between 19 to 68%. So here is an overall look of how the timeline lies out for complications from subarachnoid hemorrhage. It's divided into 3 phases, 1, 2, and 3. 1 being the acute phase, days 0 to 3, 2 being the subacute phase, days 3 to 30, and 3 being the late phase after day 30. Typically, TCDs are performed daily from day 0, post-bleed day 0, up until some institutions day 14, and some institutions carry on till day 21. But vasospasm typically occurs in the subacute phase with a peak at 4 to 10 day mark. There are certain symptoms that a patient will have when vasospasm is suspected. Confusion, agitation, apathy, or electrolyte disturbances may be caused from frontal lobe ischemia secondary to vasospasm. An unexplained increase in urinary output, otherwise called cerebral salt wasting, after subarachnoid hemorrhage may precede the onset of neurological deficits. So these are certain symptoms that may take place before vasospasm is apparent. However, there are multiple modalities that are utilized to determine if vasospasm is taking place. Some of these modalities focus on looking at the vessel directly, which include TCD, CTAs, digital subtraction angiography. Others use changes in the brain function or perfusion. This includes brain tissue oxygenation, microdialysis, CT perfusion, EEGs, thermal diffusion monitoring, near-infrared spectroscopy. Digital subtraction angiogram remains the gold standard to diagnose vasospasm. However, this is an invasive procedure and it has complications such as arterial dissections. It may induce thrombosis. So TCD is a great bedside tool. We do not have to transport the patient. We can go in and out more than once a day if necessary to determine if those mean velocities are elevated and if vasospasm is suspected. There are different parameters to review and to know when performing TCD because it will have an impact on the blood flow and the mean velocities. This includes a list of things, including hematocrit, blood pressure, CO2. Age is a factor. You can see in this chart the different arteries here. It has listed ACA, MCA, PCA, the Wirtz and Baszler. In the diagram, it shows the age from 20 to 40 years. The MCA mean velocity is 74 to 81. If you increase the age in years from 40 to 60 years, the mean velocity will decrease. 72 to 73 is the average mean velocity. And if you exceed an age greater than 60 years, the mean velocity on average is lower, 58 to 59. The mean velocities are typically highest at a younger age in life, around 10 years of age, before the mean velocities will continue to decrease as we age. And we will continue on in the next slides to review how hematocrit and blood pressure affect the blood flow. Hematocrit has another effect on our TCD mean velocities, and this relationship is an inverse relationship. So when we have a low hematocrit, TCD mean velocities can be elevated. So hematocrit is another factor to have note on your chart if it is increased or decreased, because it is an inverse relationship with our TCD mean velocities. TCD mean velocities and blood pressure. So the effects of blood pressure on our TCD mean velocities won't always have an effect. However, sometimes they may affect the blood flow. Cerebral autoregulation, when it is intact, will help regulate our cerebral blood flow. If the blood pressure were to increase or decrease, our cerebral blood flow can maintain a steady flow. However, in critical patients and patients with advanced age, this autoregulation is not as efficient. And when the blood pressure increases, you will see an elevation in the cerebral blood flow. So it is a good thing to note when performing TCDs what the patient's blood pressure is on our reports as well, because many of our subarachnoid hemorrhage patients are in critical status. Along with age, hematocrit, and blood pressure, sex and pregnancy status can have an effect on the cerebral blood flow. Women are known to have higher cerebral blood flow values compared to men. This is attributed to several hormonal factors involving the lower blood viscosity in women, effective estrogen on the brain leading to higher cerebral glucose metabolism, the lower brain weight in women, and the higher systemic blood flow in females due to higher cardiac index and lower peripheral vascular resistance. In addition, cerebral blood flow tends to increase further throughout pregnancy, reaching maximum increase of 20% above the non-pregnant value, along with decreased cerebral vascular resistance. Another factor that affects blood flow is fever. blood flow changes in response to the cerebral metabolism due to temperature variations. Hypothermia increases metabolic rate, and cerebral blood flow hypothermia does the opposite, leading a decrease in intracerebral volume and intracranial pressure. Patients with subarachnoid hemorrhage and cerebral vasospasm are often febrile, and fluctuations of cerebral blood flow in these patients could be related to body temperature variations. One other factor to review is the intravascular volume and hemodynamic factors. So cerebral blood flow is augmented by increasing the intravascular volume, as in the cases of severe anemia and insufficient delivery of oxygen to the brain in these patients. Another factor that has an effect on cerebral blood flow is CO2. Sometimes during sleep, retaining CO2 can take place. This is hypercapnia. This is common in apnea and pulmonary obstructive disorders, but can happen on healthy patients. What happens on TCD when CO2 is retained during sleep? The TCD mean velocities will elevate. If TCD is being performed with the patient sleeping, you will notice some large fluctuations in the mean velocities. If you notice these large fluctuations in the mean velocity, a note should be made on the patient's chart to ensure that the patient will have the proper care and not be treated on higher mean velocities that are secondary to retaining CO2. How does the machine calculate the blood flow? TCD, or transcranial Doppler, uses time average mean maximum velocity. This is the peak systolic velocity plus 2 of the end diastolic velocities divided by 3. This is a mean calculation that is analyzing this waveform with a Doppler equation for the physics lovers provided in the middle of the screen. TCD mean flow velocities are very important to always keep your eye on when scanning. You're looking for those high mean velocities. However, there is another parameter to watch while scanning, and that is your pulsatility index. Your pulsatility index, or your PI, will determine the resistiveness of the vessel. Now, a normal PI, as you can see on the left here, the 0.93, this is what your waveform will look like if it is your PI is in the normal range. With elevation of your pulsatility index of 1.2 or higher, the 2.0 PI and 2.5, the pictures to the right of the screen, these are your elevated PIs. When your end diastolic flow becomes minimal or absent, your pulsatility index is higher. This can take place in subarachnoid hemorrhage with signs of decreased cerebral compliance, increased cerebral edema, development of hydrocephalus, and the need for placement of intraventricular catheter for cerebrospinal fluid placement. There's a strong correlation found between the pulsatility index and ICP, or intracranial pressure. In addition, a negative moderate correlation between cerebral perfusion pressure, the CPP, and PI was also identified. So these are just things to be aware of when scanning your subarachnoid hemorrhage patients with TCD. Let's get into how to perform TCD for our complete TCD vasospasm patients. So there are 4 different windows that you will use for a complete exam. Not all institutions will use all of these windows for this type of procedure. However, we will review all 4 windows in case you decide you will use each of them. The transorbital window is the window above the eye. You'll obtain your ophthalmic and carotid siphon through this window. The temporal window, this is the window in front of the ear. This is the window we'll use for your MCAs, ACAs, terminal ICAs, and your PCAs. The suboccipital window, you will use at the back of the head, and we will obtain the vertebrals and the basilar artery through this window. The last window we'll use for our subarachnoid hemorrhage patients is the submandibular window. This is the window just below the jaw, and in this window we will obtain the extracranial internal carotid artery for the Lindengaard ratio, and which we'll review further into this presentation. Now, the temporal window is used to isolate the middle cerebral artery. This is one of the main vessels to isolate when determining vasospasm in our subarachnoid hemorrhage patients. So we'll place this probe just in front of the ear and isolate the middle cerebral artery. So as we see here, our probe placement, this is where our middle cerebral artery will lie. The blood flow will be coming towards the probe, and we will see that over here on the right. In our M mode, we'll have a red band, which is blood flow towards the probe in this large range, because we have this large middle cerebral artery that we're insunating at the depths of 30 to 60 millimeters. So the top of the skin surface is the top of the M mode. So as we travel deeper into the head, we're traveling deeper into this M mode. And as we reach the MCA-ACA bifurcation, which typically lies at 62 millimeters in an adult, we will find the ACA going away from the probe. So here is our ACA going away from the probe, and here it is in the M mode going away from the probe. Here is our MCA, here is our ACA. And if we look over on the other side of the screen, here is another beautiful MCA. We see a big, large band of red. And this image I have included so that you can see in our power M mode when there is a break within the vessel here. You can see there is black here between the red band. This can be the location where you may find your highest mean velocities. There is the most narrow portion of the artery at this area, and this is where we were seeing the highest mean flow velocities on this patient. Here we're going to walk through how to isolate the MCA. We will place an adequate amount of gel on the probe initially. We will place the probe at the temporal window just in front of the ear, angling anteriorly towards the opposite eyebrow. And you will see as I place the probe down, I'm having a good contact to the skin surface, and I'm applying adequate amount of pressure, angling towards the eyebrow. I have identified the middle cerebral artery. I won't start taking pictures initially at this point. I will make sure all my parameters on the screen are where I want them. You'll need to know how you have your scale, your power, your filter. You'll need to isolate all of those parameters and adjust them appropriately. And you will angle your probe to find the most optimal signal, ensuring you are capturing your highest mean flow velocities. And then you will walk your sample volume or cursor through the length of the vessel and capture images or pictures depending on the institution's protocol, ideally 4 or 5 millimeter increments with images taken throughout the whole length of the artery is sufficient for our subarachnoid hemorrhage patients. Next, we're going to review briefly the TCD machine controls. There are different parameters that we can adjust on our machines. The first one that we will look at is power. The power is right here on the screen. 80 or 100% is a typical default power set on your machine. When you need to decrease your power setting is with pediatric patients or with patients with hemicraniectomy. 30% power for hemicraniectomy patients when that skull is removed, and when performing the submandibular window for the extracranial ICA. If scanning over the orbital window, 10% of the maximum output power is recommended. A scale adjustment it can be made when this waveform becomes larger. Your scale needs to increase so that your waveform is fitting accurately on the screen. The baseline is right here on your screen, your 0 line. This can be moved up when you are getting flow below the baseline so that we can accurately demonstrate flow above the baseline and below the baseline. Our filter setting. The filter will minimize the background noise when higher. So if you have a low signal that you are trying to insonate, decreasing the filter could be an option. Your gain setting. When you see too much speckle in this background, you can turn your gain down. Your sample volume is typically set at 6. This can be increased when you are scanning an insufficient temporal window. I have scanned patients where I have not found a signal at all in M mode or in spectrogram, and I have increased my sample volume so that I could find a signal. Now the sample volumes can raise up to 12 and 20 in some situations. Maintaining a lower sample volume is ideal. However, increasing can be beneficial when the temporal window is insufficient. The sweep speed is usually set at 4 seconds. On average, it can be increased in situations such as rewatching a recording for a bubble exam. To review the M mode a bit further, here we have an image isolating the MCA, ACA, and contralateral ACA. This is a good image to walk through how the M mode appears. So your probe is placed here at the temporal window. We are isolating the MCA first. So this M mode is set up to have the most superficial part at the skin surface at the top of the screen. So here is at the skin surface, and we're traveling deeper into the head. So this is 30 millimeters, 40 millimeters, 50, 60, 70, and 80. Our midline of the head is usually at 75 millimeters in an adult patient. You can see this in your M mode when you can see your two ACAs meet. Where the two ACAs meet is your midline of the head. So in this picture, you have your middle cerebral artery, which your M2 segment, which we said was 30 to 40 millimeters. And then as we continue deeper, we are going into the M1 segment of the MCA. So 40, 50, 60, we're in the MCA here. And when we're listening at this section, we're going to see blood flow towards the probe, and that's why it's above the baseline here, and red. This is towards the probe flow. We don't see any flow away from the probe in the spectrogram here, but we do see it in M mode. That's because our depth is isolated in the 40s here. As we take our depth deeper, as we are scanning, and we take our depth to 60 millimeters, that's where we are identifying the MCA-ACA bifurcation on this patient. So that's when you'll have blood flow towards the probe and away from the probe. Your MCA is towards the probe, your ACA is away from the probe on your normal patients. So you'll see the blood flow towards the probe above the spectrogram and blood flow away from the probe below the spectrogram, and here is your 0 line. As you continue deeper into the M mode, you're scanning away from your middle cerebral artery and you're isolating your ACA. So here you'll see the MCA is fading away and your ACA is getting more clear. Now, in TCD for vasospasm, the protocols include the MCAs as we just reviewed in the last screen. And the ACA typically is included as well. Terminal ICA and PCA can be included in this protocol with pictures taken every 4 to 5 millimeters. Now, this patient population, it is quite important to include the Lindegaard ratio. So we are going to review what the Lindegaard ratio is and why it's so important for our subarachnoid hemorrhage patients particularly. Now, the Lindegaard ratio was investigated in 1976 with patients with aneurysmal subarachnoid hemorrhage, comparing cerebral angiogram findings to the TCD results for the diagnosis of vasospasm. They identified elevated MCAs compared to the distal extracranial ICA on TCD when there was angiographic vasospasm in the MCA. So what was happening is the blood flow in the neck was remaining normal. That was the constant flow. And the vessels at the base of the brain were clamping down in vasospasm. So the blood flow was going faster through the more narrowed segments of the arteries. Now, patients with subarachnoid hemorrhage are treated with triple H therapy and other treatment methods, which we will discuss later in this presentation. However, many of these treatment methods for subarachnoid hemorrhage will increase the cerebral blood flow, will increase the flow everywhere. So if the flow is increased secondary to the treatment provided for our subarachnoid hemorrhage patients, the flow in the neck and the flow in the head will both be elevated. So then we can determine that the patient has hyperdynamic flow and not necessarily vasospasm. If the flow is normal at the neck and high at the head, then we can determine that vasospasm is present. When obtaining our extracranial ICA through the submandibular window on our vasospasm or subarachnoid hemorrhage patients, what we will do is place that probe up underneath the jaw, the front of the neck, and isolate the ICA. The only interference that tends to happen is obtaining the ECA instead of the ICA. Now, the distinct difference between the ICA and ECA you can see here. We'll have the probe here at the front of the neck, and we are going to angle towards our ICA. We're going to get a bit distal portion than we would normally get when performing a carotid Doppler. So we are going to angle the probe for this ICA. If we obtain our ICA correctly, we will see this image over here. We will see a solid blue band through the M mode because the ICA in a normal state is low resistant. The ECA is high resistant, so you will see black between your blue in your M mode for your ECA. The spectrogram is also different between the ICA and ECA. There's more end-diastolic flow in your ICA, and typically the mean velocity is higher than the ECA on average. You will look between the depths of 40 to 60 millimeters to isolate your ICA, and here's your ECA with a more resistive or pulsatile waveform. And here are the parameters. There are two different ratios that can be used, and there are two different criteria that are very similar that are most commonly used. We will review this top image showing the mean flow velocities in the middle cerebral artery, categorizing them in mild, moderate, and severe. So when the mean velocity reaches 120, this is your mild range for vasospasm. We will also take into consideration what that Lindegaard ratio is. So we are obtaining the extracranial ICA and the middle cerebral artery, and we will divide the ICA into the MCA, the highest mean velocities, and obtain a Lindegaard ratio. Now, if that ratio is below 3, this would state it is hyperdynamic. But if that ratio has reached 3 and the mean flow velocity is at 120, we will determine this is mild vasospasm. As the mean flow velocities increase, we will have more severe vasospasm. So the moderate range you'll see here is when the mean flow velocity reaches 150, and the Lindegaard ratio is between 3 and 6. When the mean flow velocity is greater than 200 and our Lindegaard ratio exceeds 6, then that will be severe MCA vasospasm. There are some sites that include the basilar artery ratio, and that will determine an extracranial vertebral compared to our basilar artery mean flow velocity. So vasospasm in the basilar, greater than 70, greater than 85, will meet this moderate and severe range. And if including the ratio, you'll see here greater than 2, 2.5, and 3 will indicate greater degrees of vasospasm. Now, I had to include this image on this presentation because Dr. Mehmet made a beautiful image here. I contemplated recreating this type of image, but this was just too beautiful to not include and to show his hard work at getting two pictures side by side and showing the difference here between TCD imaging and TCD dedicated Doppler. So on our right side here, you'll see this is the imaging with the probe at the right side, the right temporal window, right by the ear. So this is the skin surface, and the first vessel we're going to see here is our M2. As we said, M2 we'll see between 30 and 40 millimeters in an adult patient. And then as you continue deeper, you're going to see your M1 segment. Our terminal ICA is here, and posteriorly we can see our P1 and P2. We can also see our superficial cerebral artery, our basilar artery, our P1 and P2 on the left side. We can see a bit of our ACA on the right and a little bit of the A2 coming forward. We can see the left side terminal ICA and the left MCA going away from the probe. So moving on to the dedicated Doppler image, we can see superficially 35 millimeter depth. This is our ECA branches. This is high resistive flow. There is a gap between our M mode. Here starts our MCA, so we're at 45 to 65. We've got a broad range of red here. This is flow towards the probe in red, flow above the baseline in the spectrogram. This is our MCA. Continuing deeper, we'll have our ACA, our right-sided ACA, and here's our midline of our head. We can see clearly the ACAs are meeting here at about 76 millimeters. So here's our contralateral ACA. Here's our two ACAs meeting, midline of the head, direction of flow towards the probe is red, away from the probe is blue. MCA, ACA, ACA. Great work, Dr. Mehmet. One important thing to be aware of when looking at TCD and performing TCD in your facility is the envelope tracing over the top of the waveform. The envelope tracing is what is analyzing our mean flow velocities and our pulsatility index. This envelope tracing needs to be accurately hugging the waveform. So as we can see, this white line is not tracing accurately over the waveform on this side. This mean velocity of 82 and the pulsatility index of 1.06 is not accurate. The waveform needs to be traced accurately as it is on this side of the screen, where this white line is going over the top and the bottom of this waveform as it should. This mean velocity of 124 and the PI of 1.0 is accurately identifying the blood flow on this patient. And now we're going to get into a few case studies. So this is a 56-year-old Caucasian male, status post-aneurysm coiling. The left MCA velocity of 132 centimeters per second and a left Lindegaard ratio of 3.38 is suggesting mild vasospasm. The right MCA of 103 is within normal limits. So this is showing side by side a normal mean flow velocity in the right MCA and an elevated mean flow velocity in this left MCA showing mild vasospasm. Moving along to the next case study, here we're going to show moderate vasospasm. This is a 75-year-old Caucasian female, status post aneurysm coiling as well. She is on continuous EEG. She was intubated, multiple IVs in place. Her highest mean velocities are found in the left MCA. Her left MCA is 164 centimeters per second, and her Lindegaard ratio was 5, confirming moderate vasospasm. Again, we're showing a side-by-side difference. Whenever you do look at your TCDs, you're always going to look globally. What side, one side compares to the other side. So here, the right MCA has a mean flow velocity of 64, and this left MCA has a mean flow velocity of 164, confirming moderate MCA vasospasm. And here is a 44-year-old Caucasian female, status post cerebral aneurysm coiling. The MCAs have mean velocities greater than 200 bilaterally, and the Lindegaard ratios are greater than 6. So this is suggestive of severe MCA vasospasm. So here is our mean velocity here of 202, and we have the report down on the bottom here. The Lindegaard ratio is 7 on the right and 8.3 on the left. These are high Lindegaard ratios. This is definitely confirming severe vasospasm. Now, if this mean flow velocity was 202 and our Lindegaard ratio was less than 6, this could suggest moderate to severe vasospasm. So that's how it would take place if you had mean flow velocities and Lindegaard ratio that aren't matching equivocally. You would have to say mild and moderate, moderate and severe, and combine the categories to report accurately on your TCD exam. And here is our TCD trending. So as we have said, TCDs are performed daily, typically from post-bleed day 0 or day 1 up until day 14. So this is every day a TCD being performed, ideally first thing in the morning, same time every day. All factors remain as consistent as possible. And a graph like this can be generated on nearly all machines nowadays. So basically this is showing your day 1, day 2, all throughout the days of your highest mean velocity in these vessels. So this is showing the right sided versus the left side. So our right side is in blue, our left side is in red. And as we continued throughout the whole week, ideally we would like to see these mean flow velocities decreasing as treatment is provided on our vasospasm patients. The changes in TCD mean velocities are correlated to the narrowing within the vessel that is represented on angiography. Now, the best correlations are in the MCA and the vertebrobasilar system. There are studies that show the anterior circulation comparing TCD findings to angiograms, and the sensitivity to the MCAs are far greater than other vessels in comparison ACA and PCA. So TCD mean velocities are correlated ideally with the MCAs and the vertebrobasilar system. That is one reason why we can categorize mild, moderate, and severe in the middle cerebral arteries. Moving along to our treatment options for our aneurysmal patients. So a cerebral aneurysm will form, as we had mentioned previously, ACOMs, MCA, ICA, and basilar tip most frequently. However, they can be found on any vessel within the circle of Willis. Now, aneurysm coiling is more common than surgical intervention of aneurysm clipping. However, when I first started performing TCDs, there were a lot more clippings performed, and nowadays we have a lot more coilings performed. And how the aneurysm coiling is performed is the catheter is placed in the groin, or can be radial artery accessed nowadays, and fed up into the base of the brain, and coils are inserted into the aneurysm itself. The larger aneurysms require a greater amount of coils. If the neck of the aneurysm is large, a stent is put in place to hold the coils within the aneurysm. As you can see in the diagram here, we have coils entered in, closing off this aneurysm with a smaller neck. Here is a larger neck. A stent is placed to hold those coils in. Here is a picture of what a clip would look like to obscure the neck of the aneurysm to prevent flow. And they also have flow diverting stents that can help direct the flow away from the aneurysm in an attempt to close the aneurysm completely. Along with balloon angioplasty and vasodilators, Triple H therapy is used frequently for our subarachnoid hemorrhage patients. Triple H therapy is induced hypertension, hypervolemia, and hemodilution. Triple H therapy can cause the blood flow to become faster, and this is an important reason why we include the Lindegard ratio on our subarachnoid hemorrhage patients. Now, these medications for the treatment of cerebral vasospasm in the setting of subarachnoid hemorrhage may further complicate the interpretation of TCD. An example, vasodilators and their intraarterial administration, such as miloroni, verapamil, nicardipine, or nimodipine, are all used in the treatment of cerebral vasospasm. They do not only increase cerebral blood flow, but also improve the mean transient time in ischemic regions in patients with aneurysmal subarachnoid hemorrhage induced vasospasm. Vasoactive medications are administered for the majority of subarachnoid hemorrhage patients with cerebral vasospasm to augment the cerebral perfusion, and that may further increase cerebral blood flow on TCDs by inducing further vasoconstriction of the brain vessels. These therapeutic interventions in patients with cerebral vasospasm may further complicate the interpretation of TCD findings, and that's why we include the Lindegard ratio. Verapamil is a common medication used. It's injected intraarterially to relax the vessel walls and to help prevent vasospasm before it occurs. And then also, once vasospasm occurs, it can help decrease the mean flow velocities on TCD. Often, our subarachnoid hemorrhage patients will have an EVD or an external ventricular drain in place. When this drain is in place, we are not to raise or lower the patient's head without the nurse adjusting or clamping this EVD in place. What this EVD is doing is it is used in neurosurgery to treat hydrocephalus and relieve elevated ICPs when the normal flow of cerebrospinal fluid inside the brain is obstructed. So it is draining the cerebrospinal fluid and blood from our patients. So this shows the picture down below on our left of how this external ventricular drain is set up and how we can also use it for intrathecal nicardipine treatment. This EVD not only is used to drain the cerebrospinal fluid and blood, but we can also use it to insert intrathecal nicardipine right through this EVD that's in place so that the medication can go directly to where it is needed the most. The effect of intrathecal nicardipine on TCD mean velocities. It will decrease the mean flow velocities on TCD. Intrathecal nicardipine is injected through an already existing EVD so that it can get to where it is needed the most. We are able to monitor with TCD the mean flow velocities pre, during, and post intrathecal nicardipine injection. We can monitor and watch our mean flow velocities decrease as this medication is administered. Here is another patient that we can review the effects of intrathecal nicardipine being injected through the EVD. This image here on the left shows a mean velocity of 167 in the right MCA. This was before intrathecal nicardipine was administered. The Lindegaard ratio was 6.68. After injection, the right MCA mean velocities decreased to 115 and to 120. Post injection, the Lindegaard ratio decreased to 4.48, showing the positive effects of this treatment. Let's talk a minute about ECMO. Patients on VA ECMO will have a greater difference seen in the TCD waveforms than patients on VV ECMO. VA ECMO is a vein and arterial connection, and VV ECMO is a vein and vein connection. The VA ECMO patients should not receive TCDs for cerebral circulatory arrest or for determining high mean velocities or the pulsatility indices. These parameters will not be accurate on our TCD on patients with a VA ECMO device. If the patient is on a VV ECMO, then the mean flow velocities and the PIs will be more accurately displayed, and TCD could be a bit more beneficial on these patients. When performing TCD on our subarachnoid hemorrhage patients, sometimes we will start to see elevated PIs, as we have mentioned previously. When the PIs are at 1.2 or higher, this is an elevated PI. Now, in this particular case, this patient has no end-diastolic flow and the waveform has become biphasic. This can happen over time when monitoring our subarachnoid hemorrhage patients daily. And if this takes place, you will see bilaterally oscillating blood flow in both MCAs and the basilar before we can confirm this is cerebral circulatory arrest. However, the factors that determine cerebral circulatory arrest vary depending on what country we are in. However, if you can see the time frame of change in mean flow velocities and the morphology of the waveform and have the bilateral MCAs and basilar arteries identified, you can determine that cerebral circulatory arrest is a possibility. Now, TCD is an excellent tool to identify not only increased mean velocities, the pulsatility indices, the morphology of the waveform. It is also an excellent tool for identifying emboli or microembolic signals. I have scanned several TCDs for trauma emboli monitoring for arterial dissection, and the majority of emboli that I have found have been in aneurysmal subarachnoid hemorrhage patients. So this is something to be aware of when scanning your patients to accurately identify an emboli when it is present. Now, an emboli will have a popping, snapping, chirping type sound. There's a unique sound to it, and you will also see the higher concentration of white within the M mode. It will be at a slant through the M mode because it is traveling in time, so you can see the slant. It'll match up to the higher concentration of white or a brighter line or dot within the spectrogram. So you can see these are all embolic signals that are apparent on this TCD. There are other situations that may be questionable that you may think is an emboli. If it is consistent, if you see it within every waveform, such as a brewery, it is not an emboli. This you can see the higher concentration of white in every spectrogram. This is a brewery that is present on this patient. Now, an artifact will be common, any type of movement. You will see many artifacts when you're doing TCD, and this will happen in this situation. The patient was talking, so you see the artifact outside of the spectrogram and outside of the M mode band. Now, if you do find the embolic signals, it is best to make sure that prior echo with contrast was not used within the last 24 hours. Contrast can stay within the system for 24 hours and it will appear as emboli on our TCD. So to eliminate any false emboli, make sure that that contrast was not used in the prior 24 hours. The patient doesn't have an artificial heart valve, and make sure that the patient was not currently on dialysis. If these can all be eliminated and an emboli was truly identified, it would be a good idea to perform an emboli monitoring to ensure the rate of emboli is not significant. On to a TCD report. Common reporting verbiage for our TCD completes for our subarachnoid hemorrhage patients include a transcranial Doppler was performed with a 2 megahertz probe incubating the basal cerebral arteries. No evidence of vasospasm is identified. That is average reporting verbiage that is used for a normal TCD performed. Once mean velocities are elevated, the suggestive verbiage could be the mean velocities are elevated in the right MCA, suggestive of mild, moderate, severe vasospasm, which was confirmed by the Lindegard ratio. If pulsatility indices are elevated globally, we can note elevated pulsatility indices are noted globally, which can be due to cardiac function, increased ICP, decreased cerebral perfusion pressure, or secondary to advanced age. And then also commenting on prior exams with the change or lack of change to the current exam should be mentioned on the report as well. Those trending reports are very nice to include to see the day-to-day change on our vasospasm patients. So here you can see on this picture our layout of the circle of Willis. You see all of our arteries here. Here is our right MCA, and I have circled where our higher mean velocities are. So when reading, you will go through and look at these different numbers. This mean velocity was 65 in our right ACA at a depth of 68 millimeters. So you'll review all of these different vessels and the mean flow velocities obtained, and the ones that are elevated are meeting the thresholds that we have identified earlier in this presentation. This one is 139 and this one is 123. This has surpassed the threshold of 120 centimeters per second, putting this into mild vasospasm. Now we also do want to look at the Lindegard ratio to ensure that that is elevated as well, and this is showing a 3.32, so this is greater than 3 and this is greater than 120, so this falls into a right MCA mild vasospasm. TCD and vasospasm in closing. TCD is a great tool to use in subarachnoid hemorrhage patients to easily detect the day-to-day changes. Trending vasospasm patients is always a key. The higher mean flow velocities on TCD is an indicator for suspected vasospasm in our 0 to 21 day window post-bleed. However, treatment methods should be considered and the Lindegaard ratio should always be obtained. Review TCD results and correlating exams such as CTA, angio, MRA, and clinical findings to ensure and adjust your diagnostic criteria. Remember, you can miss a high mean velocity, but you cannot fake one. Never settle for those low mean velocities and always search for your highest mean. I look forward to seeing you next time. Thanks for joining me.